We're going to start with myths. The first myth that we want to give to you is that medications are not a part of treatment. Well, it's interesting because in this new age, medications are becoming a part of treatment and one of those tools in the tool set. Right now we have 3 pharmacotherapies for opioid dependence that are FDA approved, and all of them recommend strongly that they're used in conjunction with psychosocial, educational, spiritual therapy. So therefore, medications can be used as a part of treatment, and they are only one part of the treatment process. Medications are used in treatment of many diseases, including opioid dependence. And making that final decision about whether or not medications are part of a client's treatment plan is out of the counselor's scope of practice, although counselors may refer to prescribers about using a medication, and we'll talk more about that. The second myth is that medications are drugs, and you cannot be clean if you're taking anything. We often hear that in the profession. I think that is changing, and a lot of people in here are shaking their heads that yes, that's changing. Addiction counselors and other helping professionals need to change their terminology to reflect current trends in the addiction profession. Drugs are illicit psychoactive substances that are used to achieve a high. Medications are available by prescription and are used to treat an illness, a disorder, or a disease. Millions of Americans use the patch, inhalers, or Zyban to quit smoking, and this practice is widely encouraged by addiction professionals. An addiction to opioids and physical dependence to medication used to prevent withdrawal symptoms are not the same thing. Methadone, buprenorphine, and Naltrexone occupy the same receptors in the brain as illicit opioids. Therefore, these medications can block the euphoric effects of exonerously administered opioids. I always look to Dr. Keith Crawford when I say that. Pharmacotherapies are effective. Clinical data suggests that clients perform better in treatment when psychosocial, educational, spiritual therapy is combined with appropriate psychotherapy, pharmacotherapies. Alcoholics Anonymous, AA, and Narcotics Anonymous does not support the use of medications. That's the third myth. In fact, contrary to popular belief, neither AA nor NA literature nor its founding members spoke or wrote against the use of medications as a component of a recovery plan for alcohol dependence. This belief was held by leaders of specific chapters and spread erroneously to be in the AA and NA doctrine. In your packet, you will find a brochure from AA and NA that speaks directly to the medication issue. Even today, AA and NA does not endorse or encourage participants to use prescribed medications or to discontinue taking prescribed medications for the treatment of addiction. And now I'd like to turn this over to Dr. Keith Crawford.
First of all, thank you all for inviting me this opportunity to meet you and speak with you and discuss a very important issue. And thank you, Cynthia, for your introductory comments and also for the invitation. As Cynthia mentioned, and I think we discussed this in the past, is medications are important and have a role in targeting addictions, as you all know, but addictions have 2 components. There's a behavioral component, there's a biological component, or neurologic or pharmacologic component. So the medications can target what's going on in the brain. We're going to talk about the receptors. We're going to talk about the chemistry of what goes on in the brain during addiction. But there is a behavioral component as well. And we know people develop behavioral patterns, and there's certain cues and triggers that drive the addiction. And so those have to be targeted as well. The medications do not do a good job targeting them. So there's always a balanced approach. But the medications are important. And now it may be hard for you to see some of these slides, so I'll tell you what this is telling us is the number of patients that were diagnosed with some type of substance abuse. I don't know if you can see that, that's 22 million that were diagnosed in 2006. And of that 22 million, 2 million were abusing opiates. And what a lot of people are surprised to find out is that most of those people who are abusing opiates were not heroin addicts. You all probably know that. But they were people who were on prescribed opiates. They may have gotten opiates for pain relief or pain control. And so the vast number, we're talking about 1,635,000 compared to about 300,000 who are abusing heroin. So we're talking about 5 times more people who are opiate abusers who are using prescription medications and prescription pain relievers. So this is the big problem, and this is an area that's not often understood by clinicians. A note on the terminology. You will see in the literature the term opiate, and you will see the term opioid. And a lot of times people use these two terms interchangeably. If we want to be precise about what they are, the term opiate is a chemical that is directly derived, it's a metabolite, it's a modification, it comes directly from the opium, from the poppy plant. So an opiate is more of a natural alkaloid or one of the natural derivatives, whereas the term opioid is a broader term. It includes the opiates, but it also includes the chemical derivatives, the synthesis, and other chemicals that act at this same class of receptors. So opioid is a broader, more catch-all term, and that's the term that we'll use in this presentation. Now, what we're going to quickly do is we're going to talk about the 3 categories of opiates. And this is a general approach because these categories don't just apply to opiate receptors or opioid receptors. They apply to most receptors. Most medications, most drugs of abuse can fall in one of these 3 categories. Those 3 categories are agonist, they're partial agonist, and they're antagonist. And each category interacts with the receptor in a different way, and we'll talk later in more detail about the distinctions. So the interesting thing is that when we talk about opiate dependence, we have medications that work in all 3 of these different ways, and we'll talk about those. So in general, when we talk about an opiate agonist, it occupies the opiate receptor or the opioid receptor. So this compound occupies the receptor, it activates the receptor, and it produces the responses that you all are quite familiar with that are consistent with opioid use. So pain relief. Many of us, probably most of us, have used opiates for analgesia, relief of pain. So this is an agonist response. You go to the dentist, you get some dental work done, the dentist gives you a prescription for pain. You twist your ankle, you get a prescription for pain. So the pain relief is an agonist action. The euphoria that's experienced, that's part of an agonist action. But some of these effects, as you can see on here, kind of go a little bit overboard. Some of them are agonist effects that might occur when we take a little bit too much, like you can see drowsiness down on the list. I think I can probably use this better. So the drowsiness, the slurred speech, the decrease in blood pressure, the reduction in respiratory functions. These are some of the things that can occur when someone's had a little bit too much. And then some other side effects, the constipation, the nausea. These are opiate agonist effects in the gastrointestinal tract. So most of the ones that we're familiar with are agonists, and they can be administered through a number of ways. You know that your clients and your patients use opiates by all sorts of ways. Sometimes they snort, smoke, they can give it intravenously, they can take the pills, so different routes of administration. And the duration of the effects, again, can last from those who have short duration of action to those who have longer duration of action. And this is important when we think in terms of treating opiate addiction. And as we're also going to see, for example, an agent like methadone, which has a very long half-life or a long duration of action, actually gives it benefit and gives it utility in treating opiate addiction. So now there's a category we'll talk about, which is a partial opioid agonist, a partial agonist. And these are agents that at lower doses, if you look at them, they look, oops, what did I do here? Okay. So if you look at them at lower doses, the profile of the partial and the full agonist look very similar. But when you get to higher doses, you'll see that there's a plateau effect. And you're going to see exactly what that looks like very soon in the next few slides. An example of a partial opiate agonist is a drug we'll be talking about in more detail, buprenorphine. This drug, pentazocine, I don't know how many of you are familiar with. Anyone familiar with pentazocine? Put your hand up, heard of it? Talwin. Okay, this was a drug that was developed a number of years ago. It's a partial agonist, and it was actually specifically developed so that it would have an agonist effect in relieving pain, but because it was a partial agonist, it was thought that the abuse potential would be reduced. So we wanted to get the good parts of the pain relief, the analgesia, without the concern about the addiction potential in Talwin. And then the last category, the antagonists, they bind to the receptors, but they do not activate them in any way. And an example, the drug Naloxone, that many of you are familiar with, Naloxone is actually used in treating opioid overdose. So a person that's overdosed on opiates, we'll give them an injection of Narcan or Naloxone to reverse the respiratory depression and the other features which could kill the person. And Naltrexone, another agent that we'll talk about in a little bit more detail. So this is a curve, and we're going to come back to it, but I'm just going to introduce it basically. This is something that we do a lot in pharmacology. It's called a dose-response curve. And what we do with the dose-response curve, we want to see if there is an effect of the dose of a medication or a drug on the response that we see. And what we typically see is that there is an S-shaped curve or sigmoidal relationship where at low doses you start to see small effects, and then you reach a region where slight increases in dose rapidly increase the effect, and then that plateaus off. So there's a typical S-shaped curve for a full agonist. The partial agonist looks the same way initially. As we mentioned, it plateaus off much earlier. And the antagonist does not activate the receptor at all. So we get no opiate effect, even though the agent is occupying the receptor. It's essentially blocking the receptor from other agonists. So now, in the year 2000, this Drug Addiction Treatment Act was approved, and it allowed physicians to prescribe opiates in the office setting. Now, I think many of you have clients that may have benefited from this program. I think this kind of revolutionized the treatment of opiate addiction. I think it did a lot to destigmatize those individuals who were receiving methadone or other agents in clinics. Now they don't have to go to clinics. They can go to a doctor's office. Their identity is protected. And it has done a lot to keep people in treatment having these options. So again, it's helpful because the patient can go to the office of a licensed physician or nurse practitioner. It expands the number of slots So the issue of access to treatment is addressed, and the qualifications for prescribing it. Make sure that all of the prescribers are meeting some baseline qualifications. They're properly credentialed and understand all the safety issues related to doing these types of treatments. So with that short introduction, let's dive a little bit more into the biology. We want to look at these different categories, understand a little bit better how they're working at receptors. We want to talk about what receptors are. And then we want to talk about what happens during opioid addiction and withdrawal. So that's what we're going to do in this section. So, again, we want to understand how these opiates are working. We know that these receptors are in the brain, and so we want to get an idea of what's going on. Now, basically, most of the substances that we study when we look at addiction, they are working at targets in the central nervous system, and they're affecting the functioning of the brain. And if you think of the brain and spinal cord, they're involved they actually comprise the central nervous system. They control a number of processes like thinking, learning, and judgment. And you know that many of your patients or your clients are challenged with this. If they've been addicted for a long period of time, there is a cognitive impairment. We know that occurs. And sometimes that takes a long time to kind of reverse itself, even after they've been sober for a significant period of time. Emotions are controlled through the central nervous system. And these drugs of abuse alter how people feel emotionally. They alter the emotional state. The central nervous system controls voluntary movement. So you know that patients that may be overdosed on barbiturates or benzodiazepines or opiates, their motor coordination is impaired. And sensory inputs as well are affected. So the nervous system is responding to information that is coming from all different sources. It's responding to information that's coming from inside of the body, what's going on with our internal organs. It's responding to that. It's also responding to what's going on outside of our body. So it's got to coordinate these messages that are coming in from various sources. So the unit of function in the nervous system is the neuron. It's a very, very complicated cell. Your nerves are composed of sections of these neurons. They're lined up almost like cables for communicating information. If you look at this picture of a neuron, you see that it has many branches. So information can come in from a dendrite, from other cells, processed in the cell body, and then passed on by an axon. And because it has so many branches, receives information from multiple neurons, it has the ability to respond in many different ways and modify those responses that come in. Now, in between these nerve cells is a little gap. They don't actually touch each other. They come very, very close to touching each other, but there's a little gap. And the way they communicate between cells is through the release of neurotransmitter. So this neurotransmitter is released from one neuron. It diffuses across what we call a synapse. That's what we call this gap, a synapse. And then it binds on these receptors for the neuron. These receptors are the molecular targets for the neuron. So the transmitter binds on the neighboring cell, and the neighboring cell responds accordingly. It responds based on what the neurotransmitter tells it to do. The neurotransmitter may tell it to speed up its activity. The neurotransmitter may tell it to slow down its activity. So it depends on the receptor and the neurotransmitter that's released. Now you probably say, well, why is it that there's a gap? Why can't these cells just be continuous and you'll get a quicker message? The reason is that this release of this neurotransmitter allows a very controlled response. The neuron may release a little bit of neurotransmitter, so you'll get a small response. It could release a lot of neurotransmitter, so you get a big response. You can have different neurotransmitters. So what happens is this presents a site where this information can be modulated and controlled, and it's a very efficient system. Now, one of the ways we can think of these receptors is using this lock and key paradigm. So I mentioned 3 categories. We've got agonist, we've got partial agonist, we have antagonists. Each class of these drugs are going to interact, or each class of these medications will interact a different way. All of them have to fit the receptor. So when they're released, if we look at these neurotransmitter molecules, they are released and they fit right into the receptor. So they fit into the receptor, but fitting into the receptor is not the only important thing they have to do. First, they fit in the receptor. What you can see is other transmitters that are structurally different, like these blue squares, do not fit in this receptor. They have their own receptor, but they cannot interact with this receptor. Now, if we use our lock and key paradigm, the agonist that we discussed earlier will fit into the receptor. So it's like the key that fits in the lock. The difference is that the agonist opens the lock. It opens, the door opens, so you get activation, whatever that process is. Keep in mind, in the nervous system, if you activate a receptor, that could actually cause a decrease in neuronal activity. So activation of a neuron can be increasing activity or decreasing activity. The key thing is that the agonist is going to make the neuron do something. It's going to make it do something. So lock opens, door opens, we have an agonist. The partial agonist, we can think of, the key fits in the lock, it turns the lock, the door opens, but the door doesn't open as widely as it did with the agonist. If you remember the curve we saw, the partial agonist, the response doesn't get as high. So think of the partial agonist. It opens the door, but it only does it halfway. So it's an agonist, but it's not a full agonist. The antagonist fits the lock too. The key goes right in. Problem is that doesn't turn. It doesn't turn the lock. The door doesn't open. So the agonist doesn't do anything. But guess what? While the antagonist is there, an agonist cannot come in and activate it. So that door is just locked. It's not going to come in and activate it. An example would be a beta blocker. Some people who may have high blood pressure take beta blockers. This is an antagonist. It's a beta receptor antagonist. And what it does is it blocks chemicals that stimulate the heart. It keeps them from stimulating it. Okay? So it's the same principle. The antagonist occupies the receptor and blocks it, keeping the agonist away. Now let's take this information and apply this to our discussion on opiate addiction. And again, depending on what type of addiction we're talking about, some of the key nerve chemicals are different. What is interesting is that whatever type of addiction we're talking about, whether it's nicotine addiction or addiction to barbiturates or addiction to stimulants like cocaine or methamphetamine, this neurotransmitter, dopamine, is involved. All types of addiction, even addiction like gambling, addiction to food, which I have. I like to eat. All types of addiction converge on the neuronal pathways involved in dopamine. So dopamine is what we call a reinforcer. It reinforces the behavior. It makes you want to do it again and again and again. So, regulates motivation and pleasure. Again, most psychoactive chemicals increase dopamine, as do eating, gambling, and sex. Endogenous opioids. These are our natural body's production of opioids. So yes, as I think most of you know, the body produces chemicals that act at these opioid receptors the same way as heroin or morphine or methadone do. So we have our own endogenous opioid system. And this system kicks in when we're attacked and when we're in danger. You might have heard people who have experienced a shark attack or some very traumatic incident where an animal has bitten them and injured them quite seriously, and they don't really even feel the pain until sometime afterwards, and they've gotten a safe situation, and then they look down and see the damage, and then they start to feel the pain, but initially they don't feel the pain. And so that is probably a response of the opiates, which allow the person to fight and escape the situation rather than being focused on the pain. And then another very important nerve chemical, noradrenaline, also called norepinephrine. This is involved in this fight or flight response. This is a hormone that's involved in regulating blood pressure. The beta blocker drugs or medications that I mentioned earlier that many patients take actually block some of the effects of noradrenaline or norepinephrine on the heart. But this is an important chemical in opioid dependence. It's involved in stimulating wakefulness, breathing, as we already know, blood pressure, and staying alert. So keep some of these functions in mind. And to help you keep these functions in mind, Misty Story, who develops these excellent presentations for us, has these little cute figures here. So when you see them, they'll tell you exactly what's going. Dopamine does make you feel happy. You feel good about the experience, and that reinforces your desire to repeat it. The endogenous opiates make you feel euphoria. So our own opiate system is important in the emotions that we experience of having joy or pleasure. Noradrenaline or norepinephrine, because it keeps us stimulated. It's a stimulatory neurotransmitter. Now, let's talk about opioid dependence. And we think that we understand some of the key actions that occur during opiate dependence. Two of these main activities are going to be outlined here. The key thing is that with any type of addiction, there are changes or adaptations in neuronal function. The brain is going to actually adapt. It's going to alter its chemistry. It's going to alter its receptors as a result of having the drug continuously present. So let's look at the situation of what happens normally or typically during opiate use. The opioids are ingested. They bind to their receptors. A particular region of the brain is targeted, and what it does is it suppresses the release of norepinephrine or noradrenaline. So again, norepinephrine, noradrenaline is a stimulatory neurotransmitter. The opiates are going to suppress that. And we know that opioids are depressants. So one of the ways that they act as depressants is by suppressing the release of stimulatory hormones. Okay? So that's one important action. Another important action occurs simultaneous When opioids are binding to the opioid receptor, they're actually additionally activating a different area, the ventral tegmental area and the nucleus accumbens. And many of you recognize this key area of the brain as being involved in driving addictions. And one of the reasons is it controls the release of dopamine. Again, dopamine, the reinforcer. So this release in dopamine, this is a pleasurable thing. I'm enjoying the way these opioids are making me feel. I may want to do this again. So again, the role of dopamine, the brain is remembering those feelings, and the opioid user wants to repeat that type of behavior. I don't understand why this keeps going back like this. Okay. Okay, so now, when the person is repeatedly consuming opioids, this is where the problem comes in. Okay, those changes that I reported to you just a few minutes ago, that happens with an acute exposure. Your dentist gives you some Tylenol number 3 or some Dilaudid for your pain in your mouth. You take the opioids, you're going to get that response. That response is going to go away. Things are going to go back to normal. But when you repeatedly consume something, when a pattern of addiction is developing, the brain is now confronted with the fact that it is constantly being suppressed. It's constantly being having its activity reduced because you're taking a depressant drug. And the brain does not like to be constantly depressed or constantly stimulated. It likes to maintain a balance. So while the person is taking the opioid drug, the brain is going to accommodate. I mentioned that these neurons are constantly suppressed. They're unable to release noradrenaline. So what they're going to do is they're going to try to compensate. They're going to upregulate their activity. The brain is going to change these neurons. They're going to rev it up a little bit so that the brain doesn't feel suppressed all the time. So this is an adaptation. The constant presence of the suppressing opioids makes the brain upregulate these neurons so that roughly normal amounts of adrenaline can be distributed in the central nervous system. So this is one adaptation that the brain makes. Another adaptation that the brain makes, since these opioid receptors are continuously being stimulated through the addictive process, the brain is going to attempt to desensitize these receptors. And so you've got two adaptations occurring. You've got the desensitization of the opioid receptors, and you've got the upregulation of these noradrenaline releasing receptors. That is an attempted compensation mechanism of the brain. Now, the problem is if these opioid receptors are downregulated and they're connected to dopamine, and I'm an addict and I want to feel good, since the receptors are downregulated, I'm going to need more drug to try to get the same response. So as you know, in your clients and your patients, they may start taking more and more and more just to get the same effect. And we know of other types of addictions that the patient or the client will report to you that I don't even get high anymore. I'm just trying to feel normal. They're trying to get that high because of the tolerance. The term tolerance has developed. Okay, that is part of a brain's adaptation process. Okay, so now let's say that this patient who has these adaptations that have taken place in the brain, now suddenly there are no opioids around. The person can't get a supply of heroin. So now that I really apologize for this. This has kind of got a mind of its own. So now that the patient is no longer consuming their opioids, now another imbalance is created, because remember, the brain has adapted to opioids always being around. Now suddenly they're not around. So what happens is these neurons that secrete norepinephrine are now able to increase the amount of norepinephrine they release. There's no opiate to suppress them. So then now they're actually releasing more norepinephrine. And this is what triggers some of the withdrawal symptoms. Okay, those of you who came to the session we did yesterday, we saw that when those patients were in withdrawal, what are some of the things that happen? The blood pressure, their physician monitored the blood pressure. The blood pressure went up. Okay, so increased norepinephrine. The cramps, the irritability, a lot of the things that patients complain about in withdrawal are as a result of the brain now being thrown back out of balance and increased activity of the norepinephrine. Here are some of the symptoms, and I think you're all familiar with these. I don't have to go through them. Many of them due to exaggerated increase in norepinephrine, particularly some of these like the blood pressure effects, the headaches, the insomnia, the irritability, rapid heart rate, muscle spasms. All of those can be due to this activation that occurs. And again, the length of time it takes before the patient experiences withdrawal depends on the half-life. It depends on how long the opiate normally works. So in those cases that we looked at yesterday, remember those patients, it took them 2 or 3 days even before they saw withdrawal symptoms. But that's because they were on methadone. They were being switched from methadone to buprenorphine. So methadone has a long half-life. It took about 2 days before these withdrawal symptoms appeared. If they were using a shorter acting opiate, like maybe morphine or heroin, then it would have occurred much more quickly. And this is a slide that just shows us what some of the half-lives are. Here is heroin, 3 to 4 hours, and methadone's actually not on here, but it's much longer than any of these. So now, this is an interesting pattern to keep in mind. The patient who is addicted to heroin, for example, heroin has a short time of action. So they're really alternating between periods of time where they're actively injecting and they're feeling high. When they stop injecting, they quickly have the drug, the medication, well in this case the drug, the levels drop below this safety zone here, and now they're feeling sick. And while they're feeling sick, they need to get more drug. So they find some more drug and they start the process up again. So they're going back and forth and back and forth and back and forth between these alternating levels. This is a consequence of heroin's short half-life. One of the benefits of methadone and why it was used initially in opioid dependence is that methadone, because it has a long half-life, it would keep patients in this middle range for a much longer period of time. So you didn't have the up and down and up and down and up and down, going from being high to being sick, and that type of disruption in their lives. They were stable. And we might not have been able to get them off very easy, but while they're stable, we can get them into other programs, 12-step programs, cognitive behavioral therapy, other interventions that we can use to help them totally address the problem of their addiction. Okay, so in this next section, we're going to review what the options are for opioid dependence treatments. So, again, this is a serious problem. There are a number of reasons for individuals not entering treatment. And unfortunately, one of them relates to lack of education, knowing what the options are. There are limited treatments, and one of the biggest problems is there's limited access to treatment. There are not enough outlets for people who need treatment. That's not just the case for opioid addictions, for other types of addictions as well. Again, the accessibility, the convenience, we need more funding, we need more support, we need more of you to be available to really appropriately address this shortage. And again, this is just a slide that reminds us that we have some of us different levels of training and different credentialing, but essentially, in spite of what your scope of practice is, first of all, know what your scope of practice is. Secondly, actively collaborate, build strong linkages and relationships with the physician, with the psychiatrist, with the nurse practitioner, with the pharmacist, working as a team. I think all of you would agree we have to utilize a team approach to get the best outcomes. Work with the social worker. Make sure that the patient is being addressed holistically. And I think Cynthia will talk some more about that a little bit later. So now there are actually 4 treatments that have become available. Methadone, as we're familiar with, has been available the longest. Naltrexone in 1984. LAM was approved, but it's not really being used. Buprenorphine became available in 2002. So these 3 at the top are primarily the ones that we're interested in. Naltrexone is an opioid antagonist. So again, its effects are linked to its blockade of the exogenously administered opiates. No one's going to take opiate, they're not going to inject it because they're not going to get any response with the naltrexone. It's an antagonist. It's blocking the receptor. Now, someone asked a question earlier about the potential of naltrexone to precipitate withdrawal, and it certainly can do that. And that is the reason why an individual must be abstinent from opiates for 7 to 10 days prior to treatment initiation. Okay, so this is to avoid precipitating withdrawal syndrome in a patient if we try to use it. It has no addictive properties because, again, it is an antagonist. It's not activating, it's not stimulating, it's not producing any euphoria, it's not producing any analgesia, it's not doing any of the good things that people expect to get when they take opioids, so no one's going to abuse it. So there's very low abuse potential. Methadone, again, here is a drug that's working exactly the same way. It's working at the receptors. It is a full opioid agonist, just like heroin, just like oxycodone, just like morphine. Again, so we see it's an agonist. Its use in addiction relies on its long half-life. And again, as I showed you in the previous slide, having those steady blood levels of methadone having a long half-life is very important and helps to stabilize people. They don't have the shifts from being high to being sick. So methadone use is probably very similar to nicotine replacement. If you think of a nicotine replacement approach to treating someone who's a smoker, you're giving nicotine, they're addicted to nicotine, yet you're giving them nicotine, you're giving it to them in a way that we can hopefully taper them off, give those receptors a chance to get back to normal functioning, and then curb the cravings that they have. Let's go to, I'll just mention here, again, remember that methadone is a full agonist. It does produce euphoria. it does have abuse potential. And certainly, as you know better than anybody, if clients are tapered too rapidly, they can experience some withdrawal symptoms, which can be problematic. Buprenorphine, there are two forms. We'll talk about the distinctions in more detail. There's Subutex and Suboxone. It is, as we mentioned, I don't know why this thing keeps doing this. It's a partial agonist. Again, because it's a partial agonist, the client does need to be abstinent for at least a short period until mild or moderate withdrawal symptoms appear. And this is what we saw very clearly yesterday in the cases we discussed. Two products, Subutex and Suboxone. These are both administered sublingually, not orally. So you put them under your tongue like a nitroglycerin tablet. It's absorbed very rapidly. Unlike most drugs that we swallow and are absorbed from the intestine, it doesn't go to the liver, where basically the liver removes most of the drug. It gets right into your system, and it does it very rapidly. And here's an illustration which shows the sublingual, positioning it under the tongue. There are different phases. There's induction, stabilization, maintenance, and then we attempt to actually withdraw the person so that they actually become opioid free. The induction process is basically when we're going to convert someone from whatever the opioid they're dependent on to the buprenorphine. And this can be tricky because calculating the correct dose so that the patient doesn't experience withdrawal, we want to make sure that the amount of buprenorphine that they're given will control any symptoms that we have. And so in the cases we had methadone, patients stabilized on methadone that were converted to the buprenorphine. So this is an important period. Treatment is initiated when the client experiences withdrawal symptoms. So the client has been off whatever opioid they're abusing, or in the case of methadone, we've gotten them to the lowest dose of methadone that they can tolerate to facilitate transferring over to the buprenorphine. We have some tools that can help us. The CAL scale, clinical opiate withdrawal scale, can help us rank the symptoms and determine when we can start the actual switch over. Again, if the client is on a short-acting opioid, the withdrawal is going to occur much more quickly than on a long-acting opioid like the methadone. Here they're saying less is known about it, but again, we do know that the symptoms rarely appear sooner than 48 hours after the last methadone dose. And if you remember this diagram, we see the dose response. Here's the dose of the opiate and the opioid effect, whether that's analgesia or in the case of abuse, it might be euphoria. And recall that the full agonist, we see the S-shaped curve, but if it goes up too high, there can be some consequences. Normally, this is going to plateau off. And the partial agonist, the effect is going to plateau off sooner. You're not going to get the full intensity of the effect from the partial agonist as you would from a full agonist. And then, of course, this is why Naloxone or Naltrexone do not produce euphoria and actually will precipitate withdrawal. So now, once the a maximum dose, the optimal dosage, we've got the patient where they are stabilized, they're not experiencing any side effects, any cravings. We now have this patient stabilized on a particular dose of the buprenorphine. And people can do very well in that phase. one of your colleagues suggested yesterday that patients may need to stay in stabilization longer, and this gives us a chance to implement some of the other types of interventions, some of the more behavioral focused approaches. While this person is stabilized, they're feeling okay, they're not having any symptoms, they're not having craving, they're not going out using them. Okay, they're in a good space. So let's focus on some of the issues. What's going on in your life? How can we get you to implement some of these other changes? And then maybe once we have those things solidly in place during this maintenance phase, we can consider whether we want to do a stepped withdrawal. We can gradually withdraw. We can cut down on the dose. We may not be dosing this drug. Once the patient is stabilized, we may not be dosing them every day necessarily. It depends on the patient. And again, some of these patients may best remain in a stabilization phase. We may not want to start withdrawing them. They may have, again, some of the factors, unstable living situation. They've had multiple relapses. It may be good to just keep them in that maintenance phase for a period of time. And what should that time be? We don't really know. But I think your judgment and your experience with the patient is extremely valuable to the prescriber in helping them decide when that should be. Buprenorphine is addictive because remember, it's a partial agonist, so it is an agonist. If you take buprenorphine, you will get high. You will get euphoria. You will get analgesia, so it has benefit as an analgesic. So there is abuse potential to buprenorphine. And because people recognize this abuse potential, someone's gonna take it and they're gonna try to get high. Well, you ain't gonna get high putting it under your tongue. So what are they gonna try to do? They're gonna try to inject it, crush up the pills and do some type of concoction and try to inject it. Well, that's not gonna be a very smart idea if they've been switched over to Suboxone, because Suboxone is a combination of buprenorphine and Naloxone. When you take it under the tongue, the buprenorphine is absorbed, the Naloxone isn't, so it's not a big deal. But if you try to inject it, the Naloxone kicks in and will precipitate withdrawal. So it makes your clients think twice about trying to inject the buprenorphine. If they're having problems with craving, they may need to have their dose adjusted. This is just a quick comparison. You can look at this. I think you have this table between the three agents. Again, each one targeting a different area. The partial agonist, full agonist, and antagonist, and we have all of these useful in treating opiate addiction. So just a quick recap: buprenorphine, as we know, partial receptor agonist. It acts very much like a regular agonist or full agonist at low doses, but at higher doses, the antagonist kicks in. You don't get the full response. You get that plateau that we talked about. So, what makes buprenorphine so good? Again, it's safer than methadone. And I remember talking to one of my colleagues, a psychiatrist, and she just told me how much she hated methadone. I said, well, why? And she talked about just a number of cases. She was working in pediatrics, and the number of overdoses where back in the day, some of you may remember, people would have methadone in orange juice or other things. And so the kids go to the refrigerator and they see orange juice and they pour themselves a couple of glasses of orange juice and they get sleepy. And of course, parents are delighted anytime their kids are sleepy. And so they don't disturb them or wake them up. And sadly, when the child is discovered, when a problem is suggested, they had overdosed. So the respiratory suppression with buprenorphine is kept to a minimum, and that's of extreme value. Again, we often we start with Subutex, as we saw in our cases yesterday, those who attended, and with Suboxone, we will convert a patient, particularly one that we're not sure is exactly where they want to be, to the Suboxone. And so, again, it's preferred in the maintenance phase. Again, as we mentioned, it is a partial agonist. So if you take buprenorphine, you will get high. You will experience euphoria. It is being considered as an analgesic, in which it would be a good analgesic because it does produce a good analgesia like some of the other opiates do and that they're used for. Naloxone, again, the opiate antagonist, which is co-formulated with the Suboxone. And we know that naloxone precipitates withdrawal. As we mentioned, it's not well absorbed orally, so that's not a problem. But if someone tries to get high off of their Suboxone, they've got a surprise waiting for them. They will experience full-blown withdrawal symptoms. What about the efficacy? Buprenorphine was approved based on 3 pivotal clinical studies. And some of the factors that they looked at in approving it, it was shown to clearly reduce the client's opiate use, and it helped the clients remain in treatment. It was effective as some of the other agents that are currently used for treating addiction and are well acknowledged for their benefit, and it reduced illicit opiate use. And of course, this is important. We talked about all of the high-risk behaviors and all the other problems that come with opioid abuse, the risk for HIV, the risk for hepatitis C, the sexually transmitted infections, all of those things that can have very, very nasty consequences. This is important. And these are some of the side effects. I'm not going to go through all of these, but let me just tell you, if you look at these side effects, maybe while you're waiting to get on your plane, you'll recognize that some of these side effects are probably actually opioid withdrawal symptoms. So maybe when they were doing the clinical study, if some individuals were not as well controlled or didn't have the adequate dose, they may have reported some of this, and it could have just been a matter of them not being well controlled. And so that these may not actually be side effects, but more withdrawal effects, or at least that's what I think. Basically, any medication that a patient is hypersensitive to, you should not use. There's different types of interactions and serious adverse reactions that can occur. Buprenorphine should not be administered to clients receiving opioid analgesics or actively using them. Well, why not? Because it's a partial agonist. And at a certain dose, it's actually going to act as an antagonist. It's going to block those receptors. So that could be dangerous. And then, of course, the additive effects of having different opiate compounds could put the person at risk for other problems. Very quickly, and let me tell you, this is very good news, that buprenorphine can still be used in patients that have mild to moderate liver disease. Everything that we talked about previously, all these clients that come in that have hepatitis B, that have hepatitis C, that have alcoholic cirrhosis, all of these problems would raise concern for dosing some medications, and fortunately, this is not one that we have to put on the list. It's not contraindicated with people with mild to moderate renal impairment. This is something that I'm very happy about because a lot of the patients that we want to use this in have diabetes. They have renal disease. They have diabetic nephropathy, or they have hypertensive renal disease, or HIV nephropathy. So we are very happy that this is one of the drugs that we can use safely. Again, we want to monitor our patients and determine if they may require dose reduction. This is where I think you all play an important role because you're seeing the patients, you're spending a lot of time with them, you're learning what their actual experience is with the medication. So you're going to be the first one to get any hints that they may require dose reduction. They're feeling just sleepy all the time, they can't function properly, they're nodding, then you might want to contact their prescriber and make some suggestions. There are interactions when people abuse these drugs like benzodiazepines when they're on a medication like buprenorphine. So we want to carefully monitor and screen our patients to make sure that they're not polysubstance abusers, and if they are, that problem is being addressed appropriately. These are some things that the provider will address to make sure that we minimize any medication interactions because there is a possibility. And this, of course, we already mentioned about the possibility of precipitating withdrawal. Now, we talked about, I think we know very well that these drugs that are abused, benzodiazepines and opioids, impair cognitive functions and they impair motor functions. So we want to make sure that our clients are well counseled, that particularly during the induction and stabilization phase, while your body is getting used to the medication, making sure that you're not out driving, you're not out doing dangerous tasks. You want to be cautious about that till you really have a sense for how your body is going to react to this new medication.
So this last section, I want to just go over a couple things about counseling clients who are on buprenorphine. And there is much more to this particular section that is done in the 6-hour training. So you're just going to get another tidbit. So you know that it's important matching buprenorphine with the appropriate client. So you know that the client needs to be dependent on opioids and that they wish to be treated with buprenorphine. You also know that the client is aware of other treatment options available to them and that they appropriately rely on the potential benefits of buprenorphine and are willing to engage in the therapeutic process. Because as we said, that any medication alone is not the silver bullet, that it is important to have the other treatment processes, therapeutic processes available to them. We also need to know that the client appears to be capable and willing to take it as prescribed. So no huffing, no snorting, no intravenously. So those are important pieces. Or at least you have had that conversation with them in order to evaluate whether or not you believe that they're ready to take this medication, and that they appear psychiatrically stable enough to participate. Some clients are not stable enough. Maybe they might take too much medication too often, and so they would not be appropriate for this medication. And they're not currently dependent or abusing high doses of central nervous system depressants. and the client psychosocial circumstances are conducive to treatment success. Moving on, we know that there are the four legs of treating addiction, and we use this chair as that symbolism. So we know that there are psychological symptoms that need to be treated, there are biological symptoms that need to be treated, there are social situations that need to be treated, and the spiritual. And when you take any one of those legs down and not serve that, then it's very difficult to sit on that chair. So we use that chair as a symbolism for that. Holistic treatment is the best way to treat our clients, and we know that. And this is from the NAADAC 13 principles, or often called the Blue Book. And we talk about how it is important. I know it's difficult to read that. This also is in your manual. And having a good intake process, working with the client on a treatment plan, talking about whether or not pharmacotherapy is something that fits into that treatment plan, looking at their continuing care and their other ancillary services, family services, other medical services, financial, educational, mental health, HIV/AIDS, child care, transportation. You know all of those pieces that we look at in their treatment planning process. And then, as Keith mentioned earlier, looking at the multidisciplinary team so that we have a team of professionals combining all the different parties to service that client to give them the optimal level of care. In order to be effective, we know that it's important to work on common treatment philosophies and goals, and that each member must continuously and effectively communicate with each other. So in your manual, we have put together a communication form, another form, right? A communication form between the prescriber and the addiction professional. What we often hear from prescribers is, we don't hear from our clinicians. We don't know how our clients are doing, so we're afraid to make that referral. And so in the training that we do with other prescribers, we let them know there is a way to do that. And our counselors are very well trained on forms and communication. They're used to this stuff. So all you need to do is communicate with them. Please have a way to communicate with me on a regular basis. Some prescribers like that quarterly, bi-monthly, monthly. It's up to you to work that out with them. Those forms are in your manual and also in the CD-ROM that you have in your toolkit, so you're able to download those and use them. And sometimes extra communication is required. So you all are trained in that. This isn't anything new for you. And we believe that as we train more prescribers about working with addiction professionals, that we will have more success with this in the future. Outside of the disciplinary addiction treatment team, there are other contributing factors, as you know, to healthy recovery. And often we refer to 12-step programs, other types of programs that are helpful. In referring to 12-step programs, it's important to be aware, if you're aware of certain groups that support people who are on medication versus support groups that may not support medication. We've had, and you all have had stories, I've had stories with clients that have said, you know, I'm on this medication for depression, or I'm on this medication for something else, and I go to my 12-step meeting, and they tell me, get off all your medication. You can't be clean and sober with all your medication. That doesn't happen as much today. However, it's important to be aware as much as possible what 12-step groups or other groups might be helpful for your client. We know that family support is important, and that the more family support or other support that a client receives, as well as the longer that they're in treatment, the more successful treatment outcomes will be available to that client. So bringing that family in, referring them to Al-Anon, other 12-step programs as well, helping to do family treatment whenever that is possible. And of course, you know these different skills that we use in treating clients. Be flexible. You know, particularly in the beginning, we know that our clients don't always follow those appointed times to come into your office. They may miss those. And be realistic about your expectations. particularly in the beginning. Again, we're just going over the skills that you already know. Motivational versus confrontational, and using those motivational interviewing skills, and accepting and non-judgmental. These are all parts of those things that we feel are important.